Now we are going to discuss pulmonary embolism, and it's very important topic. It is asked in medicine also, surgery also. Pulmonary embolism. Okay, so first important point, that what is the most important risk factor for pulmonary embolism? And the most important risk factor for pulmonary embolism is DVT, deep venous thrombosis. Now see the important points related to DVT, that what is the most common site of DVT is the calf or soleal vein, and what is the most common site of DVT leading to pulmonary embolism, and that is thigh vein or femoropopliteal vein. So three important points. First, that what is the most important risk factor for pulmonary embolism, and that is DVT. Second, what is the most common site of DVT, and the most common site of DVT, and that's calf or soleal vein. Clear? And third important point, most common site of DVT leading to pulmonary embolism, and that is thigh vein or femoropopliteal vein. So it's thigh vein or femoropopliteal vein. Okay, so there is a very simple concept. See, whenever there is a vein, and in the vein there is thrombus. Clear? So if the lumen of vein or caliber of vein is smaller, what happens? The thrombus is strongly adhered to the wall of the vein. That's why if the caliber of vein is smaller, there is very low chances of embolism. But what is the problem? If the vein is having larger diameter or larger caliber, here the thrombus is loosely attached. And if thrombus is loosely attached, that's why there is increased risk of pulmonary embolism. So you can see most common site of DVT is calf vein or soleal vein, but most common site of DVT leading to pulmonary embolism, and that's thigh vein or femoropopliteal vein. Now in this diagram you can see that this is popliteal vein and this is femoral vein. Clear? So here there is a thrombus in the thigh vein, right? So there is thrombus in this thigh vein. Now see, whenever there is embolism, can you see via IVC it is going into right atrium, right ventricle, and then it is going to embolize into the branches of pulmonary artery. Now see here, so here you can see this is the thrombus which is loosely attached, and then this emboli is going into IVC. So from right atrium it is going into right ventricle, and then via pulmonary artery it is being lodged into one of the branches of pulmonary artery. Now what is the problem here? In majority of cases, these emboli are lodged in the peripheral branches. That's why you will see that most of the patients who are having pulmonary embolism, these cases are clinically silent. So signs and symptoms will be dependent on the site of occlusion. If a major branch of pulmonary artery is being occluded, obviously patient will be symptomatic, and if smaller peripheral branches are involved, patient might be clinically silent. Now see the pathophysiology. So before discussing the pathophysiology, first we are going to discuss the risk factors. See, DVT is the most important risk factor for pulmonary embolism. So whatever the risk factors are there for DVT, all those are the risk factors for pulmonary embolism. So see the risk factors. And these are risk factors for both DVT and pulmonary embolism. So first is obesity. If there is prolonged immobilization, duration more than 4 days, so prolonged immobilization, duration more than 4 days, pregnancy, puerperium, and puerperium. High dose estrogen therapy also increases the risk. So high dose estrogen therapy, okay. After that, long duration surgery. So which surgery is basically the surgeries which are going to impair the mobility of the patient. So you have seen that in urological surgeries or in pelvic surgeries, what patient is not able to move after surgery, or if there is orthopedic surgery involving what pelvis, hip or lower limb, so in this case also the mobility is impaired. So long duration surgeries, especially which surgeries involving pelvis, hip or lower limb, so especially the urological surgeries and orthopedic surgeries. After that, there are hypercoagulable states. We discussed in DVT also that there are inherited and acquired hypercoagulable states which increase the risk of DVT and simultaneously increasing the risk of pulmonary embolism. So what are those conditions? Hypercoagulable states. Clear? So these hypercoagulable states are of two types. One is inherited and second is acquired. Clear? So inherited and acquired. Okay. So see what are the hypercoagulable states which are going to increase the risk of DVT and pulmonary embolism. First is paroxysmal nocturnal hemoglobinuria. Second, we discussed protein C and protein S deficiency. Factor 5 lead-in mutation. Factor 5 lead-in mutation. What are the other factors? Lupus anticoagulant, myeloproliferative disorder, malignancies. So lupus anticoagulant, okay, myeloproliferative disorders, malignancies are also going to increase the risk of hypercoagulability. So malignancy. You know that nephrotic syndrome also increases the risk. Antithrombin 3 deficiency. So nephrotic syndrome, antithrombin 3 deficiency, and history of recent MI, myocardial infarction, recent MI. Clear? So these are hypercoagulable states. Okay. So now in this whole group, what are the conditions which are inherited? So if you see this protein C, protein S deficiency and factor 5 lead-in mutation, this is inherited, and antithrombin 3 deficiency, this is inherited. Rest are acquired. Clear? So these are the risk factors for pulmonary embolism. So these are risk factors for pulmonary embolism. Clear? Now how to remember? The mnemonic is also pulmonary. Okay. So see, this is pulmonary. P means paroxysmal nocturnal hemoglobinuria, protein C and protein S deficiency. Here is U. So imagine it like V. So this is what? Factor 5 lead-in mutation. L, lupus anticoagulant. M, myeloproliferative disorders and malignancy. N, that is nephrotic syndrome. A, antithrombin 3 deficiency, and R, recent MI or recent myocardial infarction. So these are the risk factors. Now see the pathophysiology. By understanding the pathophysiology, you can easily crack most of the questions. So it's very easy to understand. See, this is the heart. These are the chambers. So this is right atrium. This is right ventricle. This is left atrium and this is left ventricle. Okay. Now see the connection. From left atrium via aorta, the blood is going to all the body organs. Clear? And via aorta it is going into artery, from artery into arterioles, from arterioles into capillaries, capillaries into venules, from venules into veins, and via veins ultimately into vena cava, and from vena cava blood is going into the right atrium. Okay, so see here, via the vena cava this blood is going to drain into right atrium like this. Okay, now what happens? From right ventricle, the blood is going into pulmonary circulation via pulmonary artery, and from pulmonary circulation blood is collected and going into left atrium via pulmonary vein. So see here it's like this. Okay, and this is the pulmonary vein. So via pulmonary vein the blood is going into left atrium. So what is this? This is aorta, this is vena cava, this is pulmonary artery, this is pulmonary vein, right? Now what happens in lungs? There is presence of alveoli, clear? And what happens? There is ventilation. So here ventilation is going to occur. Now the problem, whenever patient is having pulmonary embolism, embolus is going to obstruct one of the branches of pulmonary artery. So imagine here is the embolus. So this is the embolus, and this embolus is going to occlude this major branch of pulmonary artery. So what is the problem here? If the embolus is going to obstruct this major branch of pulmonary artery, the problem here, you can see that ventilation is there but there is no perfusion. So if ventilation is there but there is no perfusion, so what's the problem? You can see because of this there is ventilation perfusion mismatch, clear? So there is ventilation but no perfusion or decreased perfusion, impaired perfusion. So there is ventilation perfusion mismatch, and because of this mismatch there is increased anatomical dead space. So what happens? There is increased anatomical dead space, and because of increase in anatomical dead space, what's the problem? This patient will be having hypoxemia. So what kind of hypoxemia? There is arterial hypoxemia, clear? So here you can notice that there is ventilation but there is no perfusion. So there is increased alveolar arterial oxygen gradient. So what will happen here? There is increased alveolar arterial oxygen gradient, and because of this, what's the problem? These patients will be having breathlessness. So these patients will be having breathlessness, clear? So this is the simple pathophysiology of pulmonary embolism. So we discussed that if the emboli is going to occlude some peripheral branch, what? There are no signs and symptoms, means these cases can be clinically silent. And if it is going to occlude more than 60% of pulmonary circulation, in that case it can lead to sudden death also, right? So see, the clinical presentations are dependent upon the site of occlusion, clear? So clinical features. So first, 60 to 80% cases are clinically silent. Why? Because the emboli is going to occlude some peripheral branch. Okay, now see what are the signs and symptoms seen in the patients. So signs and symptoms, first symptoms and what are the signs. This is frequently asked question. Okay, so what is the most common symptom? It is dyspnea. And what is the most common sign? It is tachypnea. So two important points: most common symptom, and that is dyspnea. Is the dyspnea, clear? And what's the most common sign? And that's tachypnea. Tachypnea. Apart from dyspnea, what are the other symptoms? So these patients have chest pain, these patients have hemoptysis, and these patients have cough. So apart from dyspnea, there is chest pain, there is hemoptysis and cough. Clear? Now coming to the signs. Apart from this tachypnea, you will notice that since patient is having deep venous thrombosis also, so you will notice that these patients are having unilateral leg swelling. Apart from that, these patients have wheeze and pleural friction rub. So because of DVT, there is unilateral leg swelling. These patients have wheeze and pleural friction rub. Pleural friction rub, clear? So these are the signs and symptoms of pulmonary embolism. Now imagine a situation in which more than 60% of pulmonary circulation is occluded. So whenever there is obstruction of more than 60% in pulmonary circulation, and because of this, what will happen? It can lead to sudden death, it can lead to cor pulmonale, or there can be cardiovascular collapse. So what's the problem? If there is more than 60% obstruction in pulmonary circulation, so because of this, this can lead to sudden death. It can lead to cor pulmonale or cardiovascular collapse. Clear? If you have seen the paper of AIIMS 2 to 3 years back, there was one question that what is the criteria used for predicting pulmonary embolism, and the name of this criteria is modified Wells criteria. So what's the name of criteria used to predict pulmonary embolism? And this is modified Wells criteria, right? This is used to predict pulmonary embolism. Okay, when we were discussing DVT, we discussed excellent screening test to rule out DVT, and this was D-dimer. So see, D-dimer is excellent screening test, is having high negative predictive value. It means if D-dimer is positive, DVT may or may not be present, but if D-dimer is negative, it means there is no DVT. Okay, so another test which can be done specially to rule out DVT, and that is D-dimer. Since DVT is the risk factor for pulmonary embolism, and this D-dimer is excellent screening test because of its negative predictive value, right? It means if this D-dimer is negative, it means DVT is ruled out. So we can rule out DVT if D-dimer is negative. Now lots and lots of questions are asked about the investigations in pulmonary embolism. So see, first question, what is the best investigation for diagnosis of pulmonary embolism or investigation of choice for diagnosis of pulmonary embolism? And that is MDCT, multi-detector CT, and the gold standard investigation for diagnosis of pulmonary embolism, and that is angiography. Clear? So two questions related to investigations. First, what is the investigation of choice for diagnosis of pulmonary embolism or best investigation for diagnosis of pulmonary embolism? And this is multi-detector CT, MDCT. And the gold standard investigation for pulmonary embolism is angiography. Obviously, which one? Pulmonary angiography. So the gold standard investigation for pulmonary embolism is the pulmonary angiography. Simple. These are frequently asked questions. Now see the questions related to ECG finding. First, on ECG, what is the most common finding? And that is sinus tachycardia. But sinus tachycardia is a non-specific finding. So what is the most specific finding on ECG? And that is S1Q3T3 pattern. It is most specific, but it is generally seen in less than 12% patients. So see, on ECG, what is the most common finding? And the most common finding is sinus tachycardia. Clear? And what is the most specific finding? This is the question which is frequently asked. Most specific finding, and you have to remember this is S1Q3T3 pattern, and this S1Q3T3 pattern, it is seen only in less than 12% patients. Clear? Now how we are going to manage the patients? See, since the most important risk factor is DVT, we have to manage DVT, so we have to start anticoagulants. So in majority of patients, we start anticoagulants and we observe the patient. So see the management for most of patients, we start anticoagulants and observe the patient. So anticoagulants plus observation. Now second situation, sometimes patients are having severe right heart strain and breathlessness or shortness of breath. So in these cases we have to go for fibrinolytic treatment and radiological investigation guided catheter embolectomy. So if patient is having severe right heart strain, so severe right heart strain and there is shortness of breath, clear? So in these patients we have to start fibrinolytic treatment, clear? So start fibrinolytic treatment and radiological investigation guided catheter embolectomy. So catheter embolectomy, and this is done with the help of radiological investigation, clear? Now see a second scenario. A patient is having high risk. So patient is high risk for DVT and pulmonary embolism. So we should start anticoagulants. But the second situation, patient is high risk for DVT and pulmonary embolism and patient is having contraindications for what? Anticoagulants. So you cannot give anticoagulants, and if you will not give, there will be what? Pulmonary embolism. So in such patients we are using what? IVC filter for prophylaxis of pulmonary embolism. Okay, so for prophylaxis of pulmonary embolism, what we can use? We can use IVC filter, clear? And generally this IVC filter is used in which patients? The patients who are high risk for pulmonary embolism with contraindication for anticoagulants. So high risk patients with contraindication to anticoagulants, clear? So this is how we manage patients of pulmonary embolism. Now we are going to discuss tracheobronchial foreign body. Tracheobronchial foreign body. So what happens? There is aspiration of foreign body, clear? So it is because of aspiration of foreign body, and it's more commonly seen in toddlers. So generally the aspiration of foreign body is most commonly seen in toddlers. And what is that most commonly aspirated foreign body? It's the peanuts. So you have to be very careful whenever these kids or these toddlers are playing with especially the peanuts. So first important point, that it is because of aspiration of foreign body and it's most common in toddlers. This is a question which is asked in pediatrics as well as in surgery. And what is the most commonly aspirated foreign body? And the most commonly aspirated foreign body, and that's the peanuts, clear? So it is most common in toddlers and most commonly aspirated foreign body is peanuts. Now see, what is the most common anatomical location of this tracheobronchial foreign body? So you can see it's the right mainstem bronchus. It's here. So it's right mainstem bronchus, and in some patients it's right lower lobe, clear? So either here right mainstem bronchus or right lower lobe. So what's the most common site or most common anatomical location of this foreign body? Right mainstem bronchus or right lower lobe. Right. Now see, generally when the patients are having aspiration of foreign body, these patients are having choking and coughing. Second, the symptoms are dependent on the location of foreign body. Imagine if the foreign body is in the bronchus, clear? So what happens? These patients are having unilateral wheeze. And if a patient is having tracheal foreign body, so this tracheal foreign body can lead to total respiratory obstruction. So what are the clinical features? In majority of patients, there is choking and coughing. Clear? If there is bronchial foreign body, in that case, there is unilateral wheeze. And sometimes whenever this foreign body is in trachea, it can lead to total respiratory obstruction. So if there is tracheal foreign body, if it's in trachea, so this leads to total respiratory obstruction. Now here you can see what is the most common location is the right mainstem bronchus. So here is the foreign body. So for diagnosis we go for chest x-ray. On chest x-ray what you are going to see? Radio opaque foreign body. So in this chest x-ray you can see here that there is presence of this radio opaque foreign body, and you can see what is the location is the right mainstem bronchus. So on chest x-ray what we can see? We can see the radio opaque foreign body. Clear? Now how we are going to confirm the diagnosis? In majority of cases it is in right mainstem bronchus, so it's in bronchus, so we perform rigid bronchoscopy. So with the help of rigid bronchoscopy we are going to confirm the diagnosis, and simultaneously we are going to remove the foreign body. Okay, so diagnosis. So we saw here that on chest x-ray there is radio opaque foreign body, right, and bronchoscopy is performed. So why we perform bronchoscopy? What kind of bronchoscopy? Is the rigid bronchoscopy. So this rigid bronchoscopy is going to confirm the diagnosis, and simultaneously it helps in removal of foreign body. So confirms the diagnosis and removes the foreign body. Removes the foreign body. Now see the complications of tracheobronchial foreign body. Suppose there is solid foreign body. So if there is solid foreign body, what happens? There is air trapping. Why? What happens in airway? On inspiration there is expansion of the lumen, and on expiration there is collapse of the lumen. Clear? So whenever there is a solid foreign body, during inspiration there is expansion. So what happens? Air comes in and air passes beyond the foreign body. But during expiration, when there is collapse of the lumen, what happens? Air is not able to escape. So what happens? In these patients there is air trapping. Sometimes there is delay in diagnosis, and if there is delay in diagnosis, what will happen? There is atelectasis and infection. So what are the complications of tracheobronchial foreign body? Complications. So first, if patient is having solid foreign body, this solid foreign body can lead to air trapping, right? And if there is delay in diagnosis, so because of this delay in diagnosis there is increased risk of atelectasis and infection. Now we are going to discuss the tumors of lung and pleura. So first of all, the benign tumor. What is the most common benign tumor of lung? And it's the pulmonary hematoma. What is another question which is frequently asked in relation to pulmonary hematoma? That on chest x-ray there is popcorn calcification. Okay, so we are going to discuss in detail pulmonary hematoma, right? So first one-liner question, that this is the most common benign tumor of lung. Most common benign tumor of lung. Okay, and generally it is manifested as overgrowth of cartilage, more common in males, and generally it is seen in 4th to 6th decade. So it is manifested as overgrowth of cartilage. Simple. It is more common in males, and generally in which particular age group it is seen? 40 to 60 years. Now see the clinical features. Okay, if you see the location of this tumor, it's peripheral, and we discussed that this is most common benign tumor of lung. So since it is benign, here the tumor is having slow growth. So two important points, that the location is peripheral, right, and there is slow growth because tumor is benign. Now see the question which is asked. So see how we make the diagnosis. So if you are going for chest x-ray, here you can see there is popcorn calcification. So on chest x-ray there is popcorn calcification, and if we go for CT there is coin-like lesion. And here can you see the location? It's peripheral. So diagnosis on chest x-ray, this is the question which is asked. On chest x-ray there is popcorn calcification. Clear? This is diagnostic. And if we go for CT, on CT there is coin-like lesion, right? What is the definitive treatment? So we have to go for excision of the tumor. So the treatment is excision. So excision, this is the definitive treatment of pulmonary hematoma. Next important topic is bronchial adenoma. And see here, this bronchial adenoma is a misnomer. Now why this bronchial adenoma is misnomer? Because it is not only including adenoma. This term bronchial adenoma is going to include all tumors of tracheobronchial tree. So it's a misnomer. Why? Because it is going to include all tumors or all neoplasms of tracheobronchial tree. It's a misnomer. So what are the tumors which are included commonly and which are common also? So the most common is carcinoid tumor. In this category, the most common is carcinoid tumor. Okay. What are the other tumors? There is adenoid cystic tumors, adenoid cystic tumors. There is mucoepidermoid tumors, mucoepidermoid. Clear? So these are common tumors. Out of these, most common is carcinoid. See the percentage, 80%. And if you see the percentage of adenoid cystic, it is 10 to 15%. Clear? So this is the question, that in bronchial adenoma, what is the most common type of tumor? It's carcinoid. Now what is the term? Bronchial adenoma. Clear? So what is the most common site? Yes, the most common site is main bronchi. So the most common site is, it's the main bronchi. Clear? And what kind of growth is there? If the location is main bronchi, so there is endobronchial growth. Now see, so what is the meaning of endobronchial growth? Can you see? Here is the tumor. Clear? So there is endobronchial growth. And what kind of tumor? It's highly vascular. Endobronchial growth, highly vascular tumor. So obviously this tumor will bleed. And if this tumor will bleed, can you see what will be the symptom? The symptom will be hemoptysis. And what kind of hemoptysis? Recurrent hemoptysis. So this is the most common symptom. These patients are also having intermittent hemoptysis. Second, whenever a tumor is having endobronchial growth, can you see there is occlusion of the lumen of bronchi? Because of that, patient will be having what? Chronic cough. And what will be the complication? These patients will be having atelectasis, pneumonia, abscess formation. Why? Because there is obstruction. Clear? So see the clinical features. This is the question which is asked. Most common symptom, and that is recurrent hemoptysis. It was asked many times. So it's the recurrent hemoptysis. They can be intermittent hemoptysis, since there is obstruction, so it leads to chronic cough. Since there is obstruction, what are the complications? It can lead to atelectasis, it can lead to pneumonia or abscess formation. Clear? These are the complications. Now the location is in the main bronchi. So how you are going to diagnose the bronchial adenoma? We had to perform a bronchoscopy. So if you perform the bronchoscopy, you can easily diagnose this tumor, right? And whenever we are going to perform bronchoscopy, we take the biopsy also. So investigation of choice for diagnosis is bronchoscopy plus biopsy. But the problem, since the tumor is highly vascular, what happens? It bleeds profusely during taking biopsy, so you have to be careful. So how we make the diagnosis? We perform bronchoscopy plus biopsy. We have to be careful because tumor is highly vascular, so it bleeds profusely. What's the treatment? The treatment is surgical resection and 5-year survival. See the prognosis, 5-year survival is more than 95%. So it's the surgical resection and the prognosis is very good, 5 years survival, and that's more than 95%. Now we are going to discuss malignant mesothelioma. And the malignant mesothelioma is the most common tumor of pleura, and generally in which patients it is seen? It is seen in patients having chronic asbestos exposure. Okay, so see important points related to malignant mesothelioma. So first important point, that this is the most common tumor of pleura. Most common tumor of pleura. Simple. These patients have chronic asbestos exposure. So you will see the patients who are working in asbestos factory, these patients are at risk. So generally it is more common in males because these are the patients who are working in asbestos factory. And what is the age group? Generally around 40 years of age. So more common in males, seen at 40 years of age. The most common site is pleura. But what? The tumor is mesothelioma. So in body, this mesothelium is also present in pericardium. It is also present in peritoneum. So anywhere in the body where there is mesothelium, you can find malignant mesothelioma. So the most common site of malignant mesothelioma is the pleura. So pleura is the most common site, but it can also occur in pericardium and in peritoneum. So there can be pericardial mesothelioma as well as peritoneal mesothelioma. Now it is because of chronic asbestos exposure. So what happens? There is asbestos fibers, and especially which one? Straight amphibole fibers. So which are most dangerous? In straight amphibole fibers, there is a variety which is most dangerous, and that is crocidolite variety. So in straight amphibole fibers, the most dangerous type is crocidolite. You have to remember this name, crocidolite fibers. These are the most dangerous and responsible for malignant mesothelioma. So what are the risk factors? One is chronic asbestos exposure, and the second risk is radiation exposure. So the risk factors for malignant mesothelioma, first is asbestos exposure and second is radiation exposure. Okay, there is a very important point which you have to remember, that smoking is not a risk factor for malignant mesothelioma. Smoking is not a risk factor, and you know that smoking is a risk factor for carcinoma lung. See, chronic asbestos exposure is a risk factor for both malignant mesothelioma as well as carcinoma lung. So sometimes in exam you will find a question where a smoker is going to develop a malignancy because of chronic asbestos exposure. What is the most likely malignancy? Smoker going to develop malignancy because of chronic asbestos exposure. Most likely carcinoma lung or malignant mesothelioma. So correct answer is carcinoma lung. And if a non-smoker is going to develop the malignancy because of chronic asbestos exposure, most likely it is what? Malignant mesothelioma. So you must be knowing that smoking and chronic asbestos exposure, these are having synergistic effect for causing carcinoma lung, but smoking is not a risk factor for malignant mesothelioma. So important point in risk factors that smoking, it's not a risk factor. It's not a risk factor for malignant mesothelioma, but it is having synergistic effect with chronic asbestos exposure, for which malignancy? For carcinoma lung. So you have to read the question carefully. Now what are the pathological types? So it is of three types: epithelioid, sarcomatoid and biphasic. And out of these three, which one is most common? It is the epithelioid, which is the most common type, and epithelioid variety is having favorable prognosis. So see the types of malignant mesothelioma. So first is epithelioid, second is sarcomatoid, and third is biphasic. Epithelioid, sarcomatoid and biphasic. Out of these three, the most common type is epithelioid. So this is most common type and it's having favorable prognosis. The malignant mesothelioma is asked in pathology also, and it is asked in surgery also. Now see how the tumor looks like, how mesothelioma looks like grossly. So in this picture you can see that there is presence of discrete fibrocalcific plaques. Can you see? So presence of discrete fibrocalcific plaques on the pleural surface of diaphragm. This is one finding. Second, in more than 90% patients, there is pleural effusion. Clear? So there is discrete fibrocalcific plaque. 90% patients have pleural effusion, and that's why these patients have what? Dyspnea, chest pain, chronic cough. Since patient is having malignancy, because of malignancy these patients are having what? Weight loss. Okay, so what are the clinical features? So because of this pleural effusion, these patients have dyspnea, there is chest pain, there is chronic cough, and malignancy is there. That's why these patients have weight loss. So if we go for X-ray, what will you find? Since patients are having pleural effusion, so you will find pleural effusion on chest X-ray. Since there is pleural thickening, so you will see the generalized pleural thickening on chest X-ray. And third thing, there is shrunken hemithorax. So what are the findings on chest X-ray? In diagnosis, we perform the chest X-ray and see the findings on chest X-ray. These patients have pleural effusion. In more than 90% cases, there is generalized pleural thickening, and there is shrunken hemithorax. Okay, so we discussed that chronic asbestos exposure is a risk factor for both malignant mesothelioma as well as carcinoma lung. Sometimes it's difficult to differentiate these two malignancies. So how we confirm whether the patient is having malignant mesothelioma or carcinoma lung? So we go for thoracoscopic biopsy, or we can go for open pleural biopsy. So we go for biopsy and we use spatial markers. Right now, see this malignant mesothelioma, it's positive for cytokeratin and vimentin, but it's negative for CEA, carcinoembryonic antigen. And the carcinoma lung, it is positive for CEA, but it is negative for cytokeratin and vimentin. Okay, so how to differentiate? We perform either thoracoscopic biopsy, or we go for open pleural biopsy, right? And we use spatial staining. So it's done with spatial staining. It's done. Now see what are the markers here. In malignant mesothelioma, and this is carcinoma lung. In malignant mesothelioma, cytokeratin is positive, vimentin is positive, but CEA, this is negative. Whereas in carcinoma lung, cytokeratin is negative, vimentin is negative, but CEA, this is positive. Okay. Now, there was another question on the basis of pathological appearances. We have to differentiate carcinoma lung from malignant mesothelioma. So, see, what is the appearance of villi? So, in cases of malignant mesothelioma, there is long sinuous villi. Long sinuous villi. Clear? And in cases of carcinoma lung, there is short straight villi with fuzzy glycocalyx. So there is short straight villi with fuzzy glycocalyx. Clear? So these are the differences. 2 to 3 times this question was asked in exam. There is another one-liner, that what is the name of staging, name of spatial staging used for malignant mesothelioma, and it is known as Bouchard staging. So what's the name of staging? And this is Bouchard staging. So this is used for malignant mesothelioma. Now see what is the biggest problem with malignant mesothelioma, that there is no effective treatment option for malignant mesothelioma. That's why we have to provide supportive care in majority of patients. In certain patients we go for surgical resection, and in some patient multimodality treatment is required, like we go for surgical resection, we give chemotherapy and we give radiotherapy. So see the treatment for malignant mesothelioma, there is no effective treatment. Biggest problem, there is no effective treatment. What are the treatment options, by the way? So the options which are available, we go for supportive care, we can go for surgical resection, or we can go for multimodality treatment. And in this multimodality treatment, what we include? Surgery, we give chemotherapy, and we give radiotherapy. So this is how we manage the patients of malignant mesothelioma. Now we are going to discuss carcinoma lung, and carcinoma lung is also known as bronchogenic carcinoma. So carcinoma lung, the other name for carcinoma lung is bronchogenic carcinoma. Okay, bronchogenic. So directly or indirectly, the origin is from bronchi. So generally, it arises from respiratory epithelium of bronchi, bronchioles and alveoli. So bronchogenic carcinoma, it arises from respiratory epithelium of bronchi, bronchioles and alveoli. Right? Now see, majority of carcinoma lung arises from lung hilum, but there are exceptions like bronchoalveolar carcinoma and certain adenocarcinoma. So most of the carcinoma lung are going to arise from lung hilum. What are the exceptions? The exceptions are bronchoalveolar carcinoma and certain adenocarcinomas. Otherwise, majorities are going to arise from lung hilum. Now, there are 3 important questions which are frequently asked in relation to carcinoma lung. First, what is the most common type of lung neoplasm? So, most common type of neoplasm of lung, it's carcinoma lung. Second, what is the most common visceral malignancy worldwide? Carcinoma lung. And which malignancy is responsible for most of the deaths. So most common malignancy responsible for death, and that is also carcinoma lung. Okay, so three important questions. So first, what is the most common type of lung neoplasm? Second, what is the most common visceral malignancy worldwide? Visceral malignancy worldwide. And third, most common malignancy responsible for death. Most common malignancy responsible for death. Clear? So for all these, what is the correct answer? The correct answer is carcinoma lung. So these are the three questions which are frequently asked in exam. Clear? Most common type of lung neoplasm, most common visceral malignancy worldwide, and most common malignancy responsible for death, that is carcinoma lung. Now see the risk factors for carcinoma lung. So you must be knowing that there is one established risk factor, and that is smoking. So smoking is active or passive. Both of these are going to increase the risk. It means if you are not a smoker but your partner is smoker, so that is passive smoking, and that also increases the risk. Okay, so see the risk factors for carcinoma lung. So first is smoking, both active as well as passive. Active as well as passive. Second, if there is air pollution, especially which component? The component is radon. So air pollution, which component is mainly responsible? Is the radon. Clear? Apart from this, if there is exposure to uranium, nickel, and we discuss what else? Asbestos. So if there is exposure to uranium, nickel, and asbestos. Clear? Right? In malignant mesothelioma, we discussed that for carcinoma lung, asbestos and smoking, both of these are having synergistic effect. So what is the problem? If patient is a smoker also, asbestos and smoking, these are having synergistic effect for carcinoma lung. These are having synergistic effect for carcinoma lung, especially for adenocarcinoma. If there is presence of old infarct or scar in the lung, it increases the risk of adenocarcinoma. So if there is old infarct or scar, this is going to increase the risk of adenocarcinoma. Clear? And if there is ionizing radiation exposure, ionizing radiation exposure also increases the risk. So it's the ionizing radiation exposure. Clear? These are the risk factors for carcinoma lung. Now there is one question which is asked in surgery also and asked in pathology also, that what are the oncogenic abnormalities seen in small cell carcinoma lung, small cell, and non-small cell carcinoma lung. Okay, so see oncogenic abnormalities. This is asked in pathology as well as in the surgery. So oncogenic abnormalities, what are the oncogenic abnormalities seen in small cell lung cancer, SCLC, and non-small cell lung cancer? So in small cell lung cancer, there is overexpression of telomerase, BCL2 and MYC. So here there is overexpression of, mnemonic is TBM. How to remember? TBM. So T means telomerase, B means BCL2, and M means MYC. Okay, but in non-small cell lung cancer, there is overexpression of TBR. T means telomerase, BCL2, R means RAS. Okay, so here there is overexpression of telomerase, BCL2 and R, and that is RAS. Clear? So how to remember? TBM for small cell lung cancer and TBR for non-small cell lung cancer, right? Now see, if we see the cases of adenocarcinoma, in more than 90% patients of adenocarcinoma, there is KRAS mutation. So important point here, RAS. So KRAS mutation. This KRAS mutation is seen in more than 90% patients of adenocarcinoma. Clear? So all these are important questions. Now there are 4 terms which are asked, that what are central tumors, what are the peripheral tumors, what are the tumors which are abutting chest wall, and what are the apical tumors in relation to carcinoma lung. So see the definition first. So here you can see, if the tumor is within 2 cm of proximal bronchial tree or 2 cm of great vessels, here you can see the tumor within 2 cm of proximal bronchial tree or great vessels, this is known as central. And whenever the tumor is within 1 cm of chest wall, if the tumor is within 1 cm of chest wall, this is known as tumor abutting the chest wall. And whatever the tumors which are located between central tumors and tumors abutting the chest wall, that's known as peripheral. And what is apical tumors? If we are going to draw a transverse line just touching the arch of aorta, so this is the transverse line. So any tumor which is located above this transverse line, and that is known as apical. Okay, so what is this central tumor? The tumor located, this tumor is located within 2 cm of proximal bronchial tree or great vessels. Now see, tumor abutting the chest wall, this is tumor abutting the chest wall. So this tumor abutting the chest wall, it is located within 1 cm of chest wall. So located within 1 cm of chest wall. And whatever the tumors which are located between central and tumors abutting the chest wall, those tumors are known as peripheral tumors. And what are the apical tumors? Apical tumors, these are located above the arch of aorta, above aortic arch. So there is a line, transverse line, which is passing just above the arch of aorta, and if the tumor is located above that line, this is known as apical. Clear? So central, tumors abutting the chest wall, peripheral and apical. These are 4 types. Now it's very easy to understand. See, if central tumors are there, generally small cell lung cancer and squamous cell carcinoma, these are central tumors. And if we are talking about peripheral tumors, adenocarcinoma and large cell carcinoma, these are peripheral tumors. Now see, smoking is a risk factor for central tumors. So if there is central tumor, smoking is a risk factor, and generally smoking is not a risk factor for peripheral tumors. Okay, so see, what are the central tumors? So in central tumors, we are going to include small cell lung cancer and squamous cell carcinoma. Okay, and in peripheral tumors, we are going to include adenocarcinoma and large cell carcinoma. So it's adeno and large cell carcinoma. Simple. Now see, for central tumors, what? Smoking is a risk factor. Smoking is a risk factor. Clear? But for peripheral tumor, smoking is not a risk factor. Generally, it's not a risk factor. Okay. Now, generally central tumors are small cell lung cancer and squamous cell carcinoma, but squamous cell carcinoma can be peripheral also. It can be peripheral also, right? And generally peripheral cancers are adenocarcinoma and large cell cancer. Now see, it's very easy to understand the symptoms in carcinoma lung. So the symptoms in carcinoma lung This is because of three things. First, if there is endobronchial growth, what happens? These patients will be having what? Cough, stridor, dyspnea, wheeze, hemoptysis. And if there is involvement of peripheral chest wall, so if there is involvement of chest wall or pleura, these patients will be having pain. And sometimes there is regional spread. So suppose there is involvement of midline structures like trachea, esophagus, recurrent laryngeal nerve. So these patients will be having dyspnea, dysphagia, hoarseness of voice. Sometimes the apical tumor is involving C8 and T1 root value of brachial plexus. So this condition is known as Pancoast syndrome. In certain patients, there is involvement of cervical sympathetic trunk. So patients will be having what? Horner's syndrome. And especially the small cell lung cancer and squamous cell carcinoma, it is going to compress the superior vena cava. So there can be superior vena cava syndrome, and because of regional spread there can be malignant pleural effusion also. Clear? So the symptoms can be because of endobronchial growth, because of involvement of chest and pleura, and because of regional spread. Okay, so see what are the symptoms. So clinical features. First question which is asked, that what is the most common symptom of carcinoma lung? Clear? And you must be knowing it is cough. So most common symptom is cough, followed by dyspnea, followed by chest pain, followed by hemoptysis. So it is followed by dyspnea, followed by chest pain, followed by hemoptysis. Clear? So you will not forget this cough, which is the most common symptom. So how to remember these three? Dyspnea, chest pain and hemoptysis. So the most common symptom is cough followed by DCH. It is the cough followed by DCH. Dyspnea, cough, chest pain and hemoptysis. Now see another important question which was asked many times, that which artery is responsible for hemoptysis? Clear? So these tumors are having endobronchial growth, and because of endobronchial growth there is hemoptysis. So growth is endobronchial. So which artery? The bleeding is from bronchial arteries. So there is bleeding from bronchial arteries. Clear? So bleeding from bronchial arteries are responsible for hemoptysis. Another important question, that what is the definition of massive hemoptysis? So whenever there is expectoration of more than 600 ml of blood in 24 hours. How much? More than 600 ml blood in 24 hours. That's a massive hemoptysis. So what's the definition of massive hemoptysis? So here, expectoration of more than 600 ml of blood in 24 hours. So more than 600 ml. This question was asked in AIIMS. Clear? Now we are going to discuss the group of symptoms because of endobronchial growth, because of involvement of chest and pleura, and because of regional spread. Okay. So the symptoms are divided into three categories. First, because of endobronchial growth. Clear? So we discussed that because of endobronchial growth, what happens? There is obstruction. So there is cough, there is stridor, there is wheeze, there is dyspnea, and whenever there is bleeding from the bronchial arteries, what happens? There is hemoptysis. So there is hemoptysis. Clear? First category. Second, the symptoms because of involvement of chest and pleura. Okay, chest and pleura. So because of involvement of chest and pleura, what's the problem? There is pain. So it leads to pain, right? And the most important is what? The symptoms because of regional spread, because these are questions which are frequently asked. So symptoms because of regional spread, and it's very easy to understand. So if there is involvement of midline structures, like there is involvement of trachea, esophagus and recurrent laryngeal nerve. Clear? So if there is involvement of trachea, there is dyspnea. If there is involvement of esophagus, there is dysphagia. And if there is involvement of recurrent laryngeal nerve, there is hoarseness of voice. Second, in cases of peripheral tumors or apical tumors, whenever there is involvement of C8 or T1, and this leads to Pancoast syndrome. The tumor is known as Pancoast tumor. Symptoms are known as Pancoast syndrome. We will discuss in detail. There is involvement of root value generally C8T1, sometimes C8T1 to T2. One. Second, these patients have Horner's syndrome. Horner's syndrome. And what's the cause of Horner's syndrome? There is involvement of cervical sympathetic trunk. Okay. Third, you must be knowing that small cell lung cancer, it presents as a large mass near hilum with mediastinal lymphadenopathy. So if there is large mass near hilum with mediastinal lymphadenopathy, it is going to compress what? Superior vena cava. Some patients who are having squamous cell carcinoma also, since this tumor is also central, it is going to compress superior vena cava. And because of compression or obstruction of superior vena cava, there is superior vena cava syndrome. So what happens? These patients have superior vena cava syndrome because of obstruction. Clear? For superior vena cava syndrome, which malignancy is most commonly responsible? Small cell lung cancer followed by squamous cell carcinoma. Small cell lung cancer followed by squamous cell carcinoma. And these patients also develop malignant pleural effusion because of regional spread. So there is malignant pleural effusion. Clear? So these are the symptoms related to carcinoma lung. Now coming to the site of metastasis. So see, in certain books it's written that the most common site of metastasis from carcinoma lung is adrenal. But if we see the 11th edition of D-Vita, in that it's clearly mentioned that the most common site of metastasis from carcinoma lung is brain, followed by bone, followed by liver, followed by adrenal, followed by lung. Right? So see the metastasis. This is favorite topic of examiners. Metastasis in carcinoma lung. Okay. So question is the most common site of metastasis from carcinoma lung. And you have to remember, this is very important, it's brain, followed by bone, followed by liver, followed by adrenal. Can you see adrenal is on 4th number, followed by lungs. So there is lung to lung metastasis, right? So how to remember? The mnemonic is there. It's BB Lal. Can you see? So it's BB Lal. Brain, bone, liver, adrenal, lung. We discussed that what is the most common malignancy responsible for death worldwide? It's carcinoma lung. Why? Because carcinoma lung is notorious for metastasis. In body, it can involve any organ. And carcinoma lung is the most common primary for metastasis to 6 organs. It's the most common primary for metastasis to 6 organs. So what are those 6 organs? The mnemonic is key PABs. Okay. So another important point, that carcinoma lung, this is most common primary for metastasis to 6 organs. Key PABs, mnemonic is key PABs. Clear? So key PABs, K means kidney, E esophagus, P pancreas, A adrenal, B brain, S skin. Okay. So see, this is kidney, this is esophagus, pancreas, adrenal, and adrenal, brain and skin. Okay. So question, Out of these, what is the most common site of metastasis? So we discussed the most common site of metastasis is what? It's the brain. After that, what are the paraneoplastic syndromes associated with carcinoma lung? And this is also frequently asked in exam. Paraneoplastic syndromes associated with carcinoma lung. So see the list. Paraneoplastic syndromes associated with carcinoma lung. Clear? So first, what are the cardiovascular paraneoplastic syndromes? So these patients have thrombophlebitis and non-bacterial thrombotic endocarditis. So it includes thrombophlebitis, okay, and non-bacterial thrombotic endocarditis. Clear? Now see the metabolic paraneoplastic syndromes. Metabolic. It depends on the type of malignancy. Okay. Now imagine we are discussing small cell lung cancer. So in small cell lung cancer, there is secretion of which substances? Clear? So there is secretion of increased secretion of ACTH. Clear? There is increased secretion of antidiuretic hormone ADH and increased secretion of calcitonin. Clear? So if there is increased secretion of ACTH, it can lead to Cushing. If there is increased secretion of ADH, it can lead to syndrome of inappropriate ADH secretion. And if there is increased secretion of calcitonin, it can cause hypocalcemia. So this can lead to hypocalcemia. Now see, in carcinoma lung you will find hypocalcemia also, and you can find hypercalcemia also. So in which malignancy you will find hypercalcemia? The malignancy which is going to secrete parathyroid hormone related peptide PTHRP. And what's that malignancy? Is the squamous cell carcinoma. Okay, so if the patient is having squamous cell carcinoma, it is going to secrete parathyroid hormone related peptide, and because of this the patients are going to develop hypercalcemia. So what is the most common type of carcinoma lung associated with hypercalcemia? Squamous cell carcinoma. Okay. What are the other paraneoplastic manifestations? These patients can have acanthosis nigricans. Acanthosis nigricans. Clear? So in which case you will find this acanthosis nigricans. So here the answer is hidden, ACA. So what's this? Adenocarcinoma. Okay, so this acanthosis nigricans, this is seen in ACA, and that is adenocarcinoma. Clear? It is also associated with carcinoid syndrome, erythrocytosis, carcinoid syndrome, erythrocytosis. Clear? And there are neuromuscular paraneoplastic syndromes also. So see, what are the neuromuscular paraneoplastic syndromes? So it is going to include autonomic neuropathy and Lambert-Eaton syndrome. Autonomic neuropathy and Lambert-Eaton syndrome. Clear? And both of these are more commonly associated with which malignancy? Small cell lung cancer. Autonomic neuropathy and Lambert-Eaton syndrome. These are more commonly associated with small cell lung cancer. And there was another question related to cerebellar degeneration. So this is also seen in carcinoma lung. Cerebellar degeneration. Clear? So this is the list of paraneoplastic syndromes which is associated with carcinoma lung. Now see how we are going to make the diagnosis. So the investigation of choice for diagnosis It's biopsy. So how we are going to take the biopsy? Since most of these are having endobronchial growth, so we go for endobronchial biopsy. So how we perform this bronchial or endobronchial biopsy? We perform fiber optic bronchoscopy. So via fiber optic bronchoscopy we perform bronchial or endobronchial biopsy. Okay. So how we are going to make the diagnosis? Investigation of choice for diagnosis, and that's biopsy. So what kind of biopsy? Bronchial or endobronchial? Bronchial biopsy or endobronchial. Okay. So how we take this bronchial or endobronchial biopsy? With the help of fiber optic bronchoscopy. So we perform fiber optic bronchoscopy. Okay. Now see the second important point, and this is also asked in exam, that what is the best investigation for diagnosis and staging? Diagnosis and staging. So the best investigation for both diagnosis and staging, that is PET-CT. So if the question is asked that what is the best investigation for diagnosis and staging, clear? So here the answer is PET-CT. Okay, so if the question is investigation of choice for diagnosis, that's biopsy, and in best investigation for diagnosis and staging, and that is PET-CT. There was one question in NEET 2020 related to 8th AJCC TNM classification of carcinoma lung. So let's discuss 8th AJCC TNM classification of carcinoma lung. 8th AJCC TNM classification, okay, of carcinoma lung. So it's very easy to remember. If we see from T1A to T2B, we are just supposed to add 1 centimeter. So T1A is size up to 1 centimeter, T1B is more than 1 to 2, and T1C more than 2 to 3. T2A more than 3 to 4, and T2B more than 4 to 5 centimeter. Now, if we see T2, first, if the size is more than 3 to 5, we have to include it in T2. Okay, and if you're not bothered about size, irrespective of size, if there is involvement of main bronchus without involvement of carina, so involvement of main bronchus without involvement of carina, or there is involvement of visceral pleura, clear, or there is association or patient is having atelectasis or obstructive pneumonitis, so all these will be included in T2. So what? Involvement of main bronchus, involvement of visceral pleura, or there is association with atelectasis or obstructive pneumonitis, so all these will be included in T2. If we see T3, here in T3 the size of tumor should be more than 5 to 7 centimeter, or there is direct invasion of parietal pleura, parietal pericardium, chest wall or phrenic nerve. So if there is direct invasion of parietal pleura, parietal pericardium, chest wall, phrenic nerve, so this is included in T3. Or sometimes, suppose there is a lung cancer or tumor, and there is another tumor, means there is a separate tumor in the same lobe. So if there is a separate tumor in the same lobe, it is included in T3. And imagine a second situation, if there is a separate tumor in different lobe, then it will be included into T4. So I'm repeating, if there is another tumor or separate tumor in same lobe, it is included in T3. There is a separate tumor in same lung, means in same lung in some other lobe, it is included in T4. And if there is a separate tumor in contralateral lung, then it is included in metastasis, and that is M1. Clear? So here you can see that there is a separate tumor nodule in the same lobe. Okay, so in T3 the size should be more than 5 to 7 centimeter, or involvement of parietal pleura, parietal pericardium, chest wall of phrenic nerve, or there is a separate tumor nodule in the same lobe. Now see the T4. So T4, if the size is more than 7 centimeter, it is included in T4. Or whatever be the tumor size, if there is invasion of trachea, heart, esophagus, vertebral body, carina, recurrent laryngeal nerve, great vessels, diaphragm, mediastinum, all these are included in T4. So how to remember? The mnemonic is the GDM's VCR. Mnemonic is the GDM VCR. Clear? So it's trachea, heart, esophagus, vertebral body, carina, recurrent laryngeal nerve, great vessels, diaphragm, mediastinum. Or here you can see, if there is a separate tumor nodule, there is a separate tumor nodule in different ipsilateral lobe. So in a different lobe in ipsilateral lung. Clear? So this is T4. And if there is a separate tumor in contralateral lung, and then this is included in metastasis. So this was T1 to T4. Now see the lymph node metastasis. Lymph node metastasis is further divided into N1, N2, N3. So if you see in N1, there is metastasis in ipsilateral peribronchial and or ipsilateral hilar lymph node and intrapulmonary nodes. So there is metastasis in ipsilateral peribronchial and or ipsilateral hilar and intrapulmonary nodes. And what is included in N2, there is metastasis in ipsilateral mediastinal and or subcarinal lymph node. Okay, and if there is metastasis in contralateral mediastinal or contralateral hilar lymph node, so here you can see it is included in N3. What else is included in N3? If there is ipsilateral or contralateral scalene lymph node involvement or supraclavicular lymph node involvement. Clear? So all these are included in N3. Metastasis is also divided into 3: M1A, M1B, M1C. See the types. So if you see the metastasis, see the first thing in M1A, if there is a separate tumor nodule in contralateral lobe. So in contralateral lung, if there is a separate tumor, so it is a type of metastasis. Whenever there is tumor with pleural or pericardial nodule, or there is malignant pleural or pericardial effusion, all these are included in M1. So broadly speaking, if you see this M1A represents intrathoracic metastasis. So intrathoracic metastasis, so you saw involvement of contralateral lung, pleural pericardial nodules, malignant pleural pericardial effusion. So all these represents intrathoracic metastasis, and that's included in M1A. If it is extrathoracic, but there is single extrathoracic metastasis, that is M1B, and if there are multiple extrathoracic metastasis, that is M1C. So single extrathoracic metastasis in single or multiple organs, that is M1B, and if there are multiple extrathoracic metastasis in one or more than one organ, means single or multiple organs, so this is M1C. And what was the question in NEET? They asked that the size of tumor is 1.5 centimeter. Yes, what is the T staging? So it's what, T1B. So this is the TNM classification. Now coming to the treatment of carcinoma lung. See, it's very extensive. We are going to discuss the management of operable non-small cell lung cancer because this is frequently asked. Okay. So only one aspect we are going to discuss here. So we are going to discuss the treatment of operable non-small cell lung cancer. So since it is operable, in most of these surgery will be done. Okay, so see, if the stage is 1A, 1B, 2A, 2B, stage 1A, 1B, 2A, 2B, in these cases we go for surgical excision. So surgical excision of tumor is done. Now if the patient is having this stage 2, in these patients we have to give adjuvant chemotherapy. So after surgery, what else we give? adjuvant chemotherapy in stage 2. Clear? So after surgical resection, adjuvant chemotherapy is given in stage 2. Now see, if the patient is having stage 3A malignancy with minimal N2 involvement, clear? So in these patients, again, first we have to downstage the tumor. So how we are going to downstage the tumor? By neoadjuvant chemotherapy. So we give neoadjuvant chemotherapy. After that, we go for surgery and we perform complete mediastinal lymph node dissection. Surgery with complete mediastinal lymph node dissection. Okay. Now imagine if the patient is having N2 involvement. Here there is minimal N2 involvement. If patient is having N2 involvement, so in these patients, apart from surgery, means apart from neoadjuvant chemotherapy followed by surgery with mediastinal lymph node dissection, what else is given? We give post-operative radiotherapy. Clear? So let's see again. For stage 1A, 1B, 2A, 2B, we go for surgical excision. If the stage is 2, we have to add chemotherapy in post-operative period, that is adjuvant chemotherapy. And if the stage is 3A with minimal N2 involvement, neoadjuvant chemotherapy is given followed by surgical dissection with complete mediastinal lymph node dissection. And if there is N2 involvement, then post-operative radiotherapy is also given. So these are operable cases of non-small cell lung cancer, and this is how we are going to manage. Another question which is frequently asked in medicine, in surgery, in pathology, and that is, what is the WHO classification of carcinoma lung? According to WHO classification, there are 4 types of carcinoma lung. One is adenocarcinoma. So second is squamous cell carcinoma. Third is small cell carcinoma, and fourth is large cell carcinoma. Adeno, squamous, small cell, large cell. Okay. We discussed that there are central tumors and peripheral tumors. What were the malignancies included in central tumors? So squamous cell carcinoma and small cell carcinoma. So squamous and small cell carcinoma, these are central. So smoking is a risk factor for these malignancies. And adenocarcinoma and large cell carcinoma, these are peripheral. So generally smoking is not a risk factor. Okay, one by one we are going to discuss. First, the most common type worldwide is adenocarcinoma, and most common type in India is the squamous cell carcinoma. So first we are going to discuss adenocarcinoma lung. Okay, very important. So this is most common type. We discussed that this is peripheral. So since it's peripheral, what? It is not associated with smoking, and that's why it is seen in non-smokers. And if you see the patient profile, yes, it's totally against the malignancies. Generally, in majority of malignancies, what we have seen, that most of the malignancies are common in males, elderly males, and which male smokers. And here you can see it is seen in non-smokers, females, and young patients. This is frequently asked in exam. So it's peripheral, more common in non-smokers, females, and young patients. Now the problem, though this tumor is having slow growth, the tumor itself is having slow growth, but adenocarcinoma in situ, what? Adenocarcinoma in situ, which was previously known as bronchiolo-alveolar carcinoma. Adenocarcinoma in situ, which was previously known as bronchiolo-alveolar carcinoma, this is having tendency of aerogenous dissemination. So what? Spread via airway, that is aerogenous dissemination. So if there is aerogenous dissemination, what will happen? This tumor is having propensity to metastasize to contralateral lung or opposite lung. So in adenocarcinoma in situ, there is aerogenous dissemination, and because of this aerogenous dissemination, means transmission via airway, there is metastasis to contralateral lung. So it can metastasize to contralateral lung. Clear? Which special type? Adenocarcinoma in situ. In short, previously it was known as bronchiolo-alveolar carcinoma, and in short that is known as BAC. So you have to remember this. There is a special classification which is used for adenocarcinoma. This is one-liner question. And what's the name? Noguchi classification. Clear? So there is a special classification used for adenocarcinoma, and this is Noguchi classification. Clear? Now see the other special features or other unique things, the important points related to adenocarcinoma. It is associated with clubbing. Adenocarcinoma, we discussed, it is associated with acanthosis nigricans. Okay, and you must be knowing that there is migratory superficial thrombophlebitis associated with malignancy. We discussed most common malignancy associated, carcinoma pancreas, but carcinoma lung is also associated. Which variety? Adenocarcinoma. So what? There is thrombophlebitis. Okay, which type? It's the migratory superficial thrombophlebitis, and we discussed infarct or scar is a risk factor for adenocarcinoma. So there is scar or infarct. So it is associated with scar or infarct. Since scar or infarct increases the risk of malignancy, which one? Adenocarcinoma. It is also known as scar cancer. Clear? So these are special features. Now how to remember? Can you see? Cats. Mnemonic is cats, and these are seen in adenocarcinoma. So how to remember? Mnemonic is adenocats. So adenocarcinoma is associated with clubbing, acanthosis nigricans, thrombophlebitis, scar or infarct. Now look at this tumor and tell me the type. See, this is a hilar tumor. So hilar mass. Okay. So here you can see there is hilar mass. Location is central. Okay, so hilar mass, it is central in location. So we discussed squamous cell carcinoma as well as small cell lung cancer can be central. But see here you can see that it is having necrosis and cavitation. Can you see? So what you can see here, you can see that there is necrosis and cavitation, and necrosis and cavitation, this is mainly seen in squamous cell carcinoma. So central location with necrosis and cavitation. So this is suggestive of squamous cell carcinoma. And what are the important points? First, it is central. That's why it is more common in smokers. Okay. What? It is associated with necrosis. Here you saw, and cavitation. And we discussed worldwide most common type is adenocarcinoma, but the most common type in India, that is squamous cell carcinoma. So this is most common in India. Clear? Now we discussed that in squamous cell carcinoma there is increased secretion of what? PTHRP. There is increased secretion of PTHRP, parathyroid hormone related peptide, and because of this squamous cell carcinoma is associated with what? Hypercalcemia. So these malignancies are associated with hypercalcemia. Okay. Now 2-3 important points. We discussed that this is central, but what? Squamous cell carcinoma can be peripheral also, and we discussed sometimes there is one tumor near apex of lung involving root value C8T1. So these are Pancoast tumors. So if you see the histological type of Pancoast tumors, yes, most commonly the Pancoast tumors are squamous cell carcinoma. Which type of? Peripheral squamous cell carcinoma. So if you see the histological type, it is squamous cell carcinoma. followed by adenocarcinoma, followed by large cell carcinoma. So if you see histological type responsible for Pancoast tumor, that is squamous cell carcinoma. Which type? Peripheral. So how to remember? The mnemonic is Pancoast Sala. So can you see? Pancoast Sala. S means squamous cell carcinoma, A means adenocarcinoma, and LA means large cell carcinoma. And see what is the good thing about squamous cell carcinoma, that it is having best prognosis. So this is associated with best prognosis. Now see this tumor. Here you can see that there is hilar mass. Can you see? Hilar mass, okay, with mediastinal invasion, and in these malignancies there is mediastinal lymphadenopathy. So massive hilar or mediastinal lymphadenopathy. So this is suggestive of small cell carcinoma. So what is this? This is small cell carcinoma. Okay, so we are going to discuss small cell carcinoma. So the term is self-explanatory. It's written, the cells are small, and these small cells are having little cytoplasm. That's why it is also known as oat cell. So small cells with little cytoplasm, and that's why it is also known as oat cell. So what is the other name? Oat cell. So though the cell is small, it's the most malignant type of carcinoma lung. So this is most malignant. Okay, we discussed 2-3 important things. What? That the distribution is central. So it's central, most strongly associated with smoking. Central, and it is most strongly associated with smoking. Clear? Now see here, we discussed that there is hilar mass with mediastinal or hilar lymphadenopathy with mediastinal invasion. So here you can see these tumors are having large perihilar mass. There is mediastinal invasion, and apart from this there is massive lymphadenopathy. What kind of? Massive hilar or mediastinal lymphadenopathy. Clear? So this question was asked in a description in one of the exam, that a patient was having carcinoma lung, and when surgeon was doing dissection, there was large hilar mass with mediastinal invasion and massive hilar lymphadenopathy. So most probably what type of malignancy is this? Small cell carcinoma. Now see, near hilum, if there is large mass mediastinal lymphadenopathy, so this is the malignancy which is responsible for compression of superior vena cava. And because of compression of superior vena cava, these patients will be having superior vena cava syndrome. So the question is asked indirectly, that which malignancy is most commonly responsible for superior vena cava syndrome? It's the carcinoma lung. Which type? It is the small cell lung cancer. So because of this, what happens? There is superior vena cava syndrome. Why? Because there is superior vena cava obstruction. So we discussed that this is most malignant, but see, this is most responsive to chemotherapy, and it shows response to radiotherapy also. So two important points, that this is most responsive to chemotherapy. And generally, which agents we give? In this case, we give cisplatin and etoposide. So the agents which we give, and that is cisplatin plus etoposide. And second important point, that it shows response. So these are responsive to radiotherapy also. Another important topic related to small cell lung cancer, that what are the hormones produced? What are the hormones produced by small cell lung cancer? Okay, so first we discussed in paraneoplastic manifestations, it is going to secrete ACTH, gastrin releasing peptide. We discussed there is excessive secretion of calcitonin, arginine vasopressin, and atrial natriuretic factor. Atrial natriuretic factor. Clear? Now, we discussed that because of increased ACTH, what happens? They can be Cushing. Because of calcitonin, these patients may develop hypocalcemia. And if there is increased secretion of arginine vasopressin, that is antidiuretic hormone, so what will happen? There can be SIADH, syndrome of inappropriate ADH secretion. Right? Now, how to remember? See, आ गया CAA. So the mnemonic is आ गया CAA. Okay. So ACTH, gastrin releasing peptide, calcitonin, arginine, vasopressin, and atrial natriuretic factor. These are the hormones whose secretion is increased in small cell lung cancer. The fourth is large cell carcinoma. Large cell carcinoma. So we discussed that this large cell carcinoma is peripheral and it is seen in non-smokers. So first important point, that this is peripheral and that's why it is seen in non-smokers. Now another problem with large cell carcinoma, that these are undifferentiated, and if this tumor is undifferentiated, so if this tumor is undifferentiated, what's the problem? There is early metastasis. And if there is early metastasis, what is the problem? There is poor prognosis. So there is poor prognosis. Large cell carcinoma is undifferentiated, there is early metastasis, and that's why it is associated with poor prognosis. We discussed that cavitation is seen in squamous cell carcinoma. Most commonly, cavitation is seen in squamous cell carcinoma, but cavitation can be seen in large cell carcinoma also. So here also you can see the cavitation, right? Now, if the patient is having large cell carcinoma, in these there is increased secretion of estrogen. And if there is increased secretion of estrogen, what is the problem? These patients may develop gynecomastia. Clear? So question is asked that which type of carcinoma lung is associated with gynecomastia? So it's the large cell carcinoma. How to remember? In large cell carcinoma there is large breast in males. There is large breast in males. Clear? So there is gynecomastia. So these are important points related to various types of carcinoma lung. Now we are going to discuss Pancoast tumor. What is the other name of Pancoast tumor? It is also known as superior sulcus tumor. Okay. So Pancoast tumor. It is also known as superior sulcus tumor. Okay. It is very easy to remember. See. Two things. First, the tumor is known as Pancoast tumor, right? But the manifestations because of this Pancoast tumor is known as, the clinical manifestations because of Pancoast tumor is known as Pancoast syndrome. Now we discussed, generally it is seen in peripheral malignancies, and if we see the histological types, we discussed that most commonly it is because of squamous cell carcinoma, followed by adenocarcinoma, followed by large cell carcinoma. So see the histological types. It is squamous cell carcinoma, followed by adenocarcinoma, followed by large cell. So what was the mnemonic? It's the Pancoast Sala. So it was Pancoast. Clear? Right? We discussed that mostly the squamous cell carcinoma is central, but peripheral type of squamous cell carcinoma is going to involve or invade root value of brachial plexus C8 T1, sometimes T2 also. So because of this, there is Pancoast syndrome. Now in this tumor, there is involvement of root value C8 T1, sometimes T2. So C8 T1 to T2, it represents which nerve? So it's the root value of ulnar nerve. Clear? So you will see the manifestations in distribution of this ulnar nerve. So initially this patient is having insidious onset of pain, and that starts from upper arm. Clear? But what happens over a period of time, these patients are going to develop sensory disturbances in the forearm and hand. Which aspect? Can you see the medial aspect of forearm and hand? And if you are going to examine the hand, you will notice that there is atrophy of intrinsic muscles of hand and what? Atrophy over this hypothenar aspect. And sometimes there is involvement of cervical sympathetic trunk, and if there is involvement of cervical sympathetic trunk, these patients will be having what? Ipsilateral Horner syndrome. Okay, so these are the manifestations. So what are the manifestations? Initially there is insidious onset of pain. Insidious onset of pain. Clear? And generally it starts where? Upper arm. Okay, after that these patients are having sensory disturbances, and where exactly? The medial aspect of forearm and hand. So it's the medial aspect of forearm and hand. Clear? And if we examine, there is atrophy of intrinsic muscles of hand. So these muscles are supplied by ulnar nerve. Clear? And if you examine, there is atrophy over this hypothenar aspect. Simultaneously, these patients are also having ipsilateral Horner syndrome if there is involvement of cervical sympathetic trunk. Simple. These are the manifestations. Now how we are going to make the diagnosis? See, for Pancoast tumor, the diagnosis is made by MRI. Generally, for most of the thoracic abnormalities, the radiological investigation which is preferred, especially in case of malignancies, yes, that is CT. But here, since there is involvement of root value CA-T1 of brachial plexus, so since there is involvement of nerves, the preferred investigation is MRI. So investigation of choice for diagnosis is MRI. Investigation of choice for diagnosis. Clear? And that's MRI. So how we treat? First we give preoperative radiotherapy and followed by en bloc resection of lung and chest wall. So the management, first we give preoperative radiotherapy followed by en bloc resection of lung and chest wall. En bloc resection of lung and chest wall. Okay, plus minus we go for post-operative radiotherapy or brachytherapy. So plus minus post-op radiotherapy or brachytherapy. Clear? So this is how we are going to manage the Pancoast tumors. Now we are going to discuss cardiac tumors. So first of all, we are going to discuss one-liner questions which are asked about cardiac tumors. So see, cardiac tumors. Okay. So first question, that what is the most common primary cardiac tumor, and that is myxoma. So first question, most common primary cardiac tumor, and that is myxoma. Now see the second question, most common malignant tumor of heart in adults. Okay, so if you see the vascular channels, what is the most common malignant tumor in the vascular channels? So that is angiosarcoma. So in adults also, most common malignant tumor of heart is angiosarcoma. Okay, so second important point, most common malignant tumor of heart in adults, and that is angiosarcoma. That's angiosarcoma. Okay, now see the questions related to tumors of heart in children. What is the most common benign tumor of heart in children? Benign tumor, and that is rhabdomyoma. And most common malignant tumor of heart in children. So make rhabdomyoma malignant. So this is rhabdomyosarcoma. Okay. So second question, most common benign tumor of heart in children. In children. Clear? And that's rhabdomyoma. This is rhabdomyoma. Clear? And see the second important point, most common, make it malignant. Most common malignant tumor of heart in children. So make rhabdomyoma malignant. So this is rhabdomyosarcoma. So in short, it's known as RMS, rhabdomyosarcoma. Now coming to the valves, cardiac valves. So what is the most common tumor of cardiac valves? It is papillary fibroelastoma. So most common tumor of cardiac valves, right? And it is papillary fibroelastoma. Papillary fibroelastoma. Now see, we discussed about metastasis to heart. So what is the most common primary responsible for metastasis to heart? In males it is carcinoma lung, and in females it is carcinoma breast. So whenever there is metastasis to heart, what is the most common site or most common site of involvement? So generally there is involvement of pericardium. Okay, so important question, what is the most common site of involvement? Most common site of involvement in cardiac metastasis. Okay, and it is pericardium. Pericardium. Clear? We already discussed what is the most common primary for metastasis to heart. So in males it is carcinoma lung, and in females it is carcinoma breast. So these are the one-liner questions. The most important is myxoma, and the most common site of myxoma is atrium. Which atrium? Left atrium. So it is known as atrial myxoma. So we are going to discuss in detail atrial myxoma. So see the questions related to atrial myxoma. So first, we already discussed that this is the most common primary cardiac tumor. This is most common primary cardiac tumor. Generally it is seen in females, and in which particular age group it is seen? It is seen in 30 to 60. So more common in females, and what age? 30 to 60 years. Clear? Now see, in 90% cases it is sporadic, and in 10% cases it is familial. And in familial cases it has been seen that there is autosomal dominant transmission. So if you see the inheritance here, in 90% cases it is sporadic, and in 10% cases it is familial. Clear? And in familial cases, what kind of transmission is there? There is autosomal dominant transmission. So we already discussed that what is the most common site? Atrium. Which atrium? Left atrium. And usually it is going to arise from interatrial septum. And in majority of cases there is a single tumor. So it's solitary. So it is solitary, usually single. And the most common site is left atrium, and exactly it is going to arise from interatrial septum. Exactly where? It is going to arise from interatrial septum. Okay. Now it is associated with Name syndrome and Lamb syndrome. So what are the components of Name syndrome and Lamb syndrome? So it is associated with Name syndrome and Lamb syndrome. Okay, so see the full form. So see the components. N means nevi, A means atrial myxoma, M means myxoid neurofibroma, and E means aphellates. Okay, so the components are nevi, atrial myxoma, there is myxoid neurofibroma, and E means aphids. Okay, so aphids. Now see this Lamb syndrome. Here L means lentigenes, AM means atrial myxoma, and B means blue nevi. Okay, so L lentigenes, AM means atrial myxoma, clear, and B, and that's blue nevi. Okay, so these are the components. Now see the exact location and what are the clinical manifestations of atrial myxoma. So if you see the tumor, generally this tumor is solitary. And what is the origin? The most common site is this left atrium, and exactly it is going to arise from what? Interatrial septum. So can you see here? This is the myxoma. Okay. Now see the relation of this tumor with valve. What's the name of this valve? This is mitral valve. So sometimes what's the problem? It is going to occlude this valve. So there is mitral valve obstruction. Sometimes there is mitral regurgitation or mitral stenosis. So the patients of atrial myxoma are having signs and symptoms which mimic mitral stenosis, mitral regurgitation, mitral valve obstruction. One. Second, sometimes the fragments of this tumor are going to detach from the tumor, and these fragments are going to embolize. So from left atrium it is going into left ventricle, and from left ventricle it is pumped into the arterial circulation. Because of this systemic embolization, if CNS is involved or the arteries which are going to perfuse the brain, those arteries are involved, these patients are having neurological deficit. Clear? So see the relation, it's easy to remember. Clinical features. So there are signs and symptoms related to mitral stenosis, mitral regurgitation, and mitral valve obstruction. One. Second, there is systemic embolization, and because of this systemic embolization, certain patients have neurological deficit. So what? There is neurological deficit. Apart from these symptoms, patients are also having fever and weight loss. Fever and weight loss. Clear? So these are the clinical features or symptoms in relation to atrial myxoma. So how we are going to make the diagnosis? It is performed, diagnosis is made by 2D echo, and this 2D echo can be performed transthoracic or transesophageal. Okay, so what is the investigation of choice for diagnosis? Investigation of choice for diagnosis, and that is 2D echo. Clear? So we can perform either transthoracic echocardiography or we can perform transesophageal echocardiography. Okay, now see how we are going to treat. We have to remove the tumor, so we have to perform surgical excision, but whenever we are performing the surgical excision, we have to go for cardiopulmonary bypass. So the treatment is surgical excision with cardiopulmonary bypass. Cardiopulmonary bypass. Now in certain cases there are chances of recurrence. So what are the causes of recurrence in familial cases and sporadic cases? So in familial cases, if it's multifocal, right, then it can lead to recurrence. And in sporadic cases, if there is inadequate removal of the tumor, that can lead to recurrence. So see what's the cause of recurrence. Recurrence can be seen. So if it's a familial case, in familial cases there are multifocal lesions. Okay, multifocal lesions. And if it's a sporadic case, so in sporadic cases, what? The recurrence is because of inadequate resection. So it is because of inadequate resection. Clear? These are important points related to atrial myxoma. Now see this picture. What you can see? You can see that there is posterior sternal depression And what else you can see? That there is overgrowth of or prominent lower costal cartilage. So the name of this condition is pectus excavatum. What's the name? This is pectus excavatum. Okay. It is also known as funnel chest. Can you see the shape? So it is looking like funnel, and that's why this is also known as funnel chest. This is the most common chest wall deformity. Now see what is the problem here. You see, this is the chest wall. So whenever there is overgrowth of this lateral costal cartilage, what will happen? Can you see? So because of this overgrowth of this lateral costal cartilage, lower lateral costal cartilage, what happens? Yes, there is posterior sternal depression, and if you see the shape, it is looking like funnel, and that's why it is known as funnel chest. So we discussed that this is the most common chest wall deformity. What's the incidence? It's 1 in 400 live births. So the incidence is 1 in 400 live births. Okay. So what is the problem here? Because of this posterior sternal depression, can you see? There is midline narrowing. Can you see? Here, so you can notice here that there is midline narrowing of thoracic cavity. So see the findings here. In this case, there is midline narrowing. So there is midline narrowing of thoracic cavity. And what is the cause of this midline narrowing of thoracic cavity? There is excessive growth of lower costal cartilage. So excessive growth of lower costal cartilage. And because of this excessive growth of lower costal cartilage, there is posterior sternal depression. Okay, posterior sternal depression. Simple. Now, what is the good thing? That in majority of patients, there are no symptoms. So, majority of patients are asymptomatic. In certain patients, what's the problem? Because of this posterior sternal depression, they have reduced exercise capacity or reduced work tolerance. Major problem that in children, because of this problem, these children are bullied by their batchmates or their classmates. So because of this bullying, the kids are going to develop some kind of psychological or psychiatric problems. This is the only problem. So whenever we are planning the management, in diagnosis we go for pulmonary function test to assess the pulmonary function. For assessment of cardiovascular status, we go for 2D echo and we perform CT also. So clinical features, most of the patients are asymptomatic. Okay, in certain patients, the patients who are symptomatic, what is the symptom? There is decreased exercise tolerance. So the most common symptom is decreased exercise tolerance. Okay, this is the most common symptom. But the main problem in kids is the psychological stress because of this cosmetic deformity. So because of this cosmetic abnormality, there is psychological stress in children. Clear? So see, what are the investigations which are performed? So in diagnosis, what we do, we have to go for pulmonary function test. Why? To assess the baseline pulmonary function. To assess the cardiovascular status, we go for 2D echo. 2D echo to assess the cardiovascular status, and we have to perform CT scan. Why we perform CT scan? Because we have to calculate the Haller's index. Okay, so we do CT scan to calculate the Haller's index, and this is the question which is asked in pediatrics also, and it is asked in surgery also. Haller's index. So what is this Haller's index? It's the ratio of width of chest wall to the depth of sternum to vertebral body. Okay, so it is the ratio of width of chest wall, okay, to the depth of sternum to the vertebral body. So depth of sternum to vertebral body. So this is Haller's index. So what's the treatment? See, the best results are obtained by surgery only. And what kind of surgery? Early surgery. It should be performed between 2 to 8 years of age, right? So treatment, the best results are seen if early surgery is done. So early surgery in what particular age group? If it's performed between 2 to 8 years. Clear? Now what are the indications of surgery? So see, indications. So it's related to cosmesis. Second, psychosocial factors. And third, if the patient is having respiratory or cardiovascular insufficiency. So the indications of surgery mainly related to cosmesis, psychosocial factors, okay, and respiratory or cardiovascular insufficiency. Clear? Now what are the names of procedures which are done for pectus excavatum? One is Ravage procedure and second is Nuss procedure. This Ravage procedure is performed by open approach and the Nuss procedure is performed by minimally invasive approach. Okay, so you have to remember the names. One is Ravage procedure and the second is Nuss procedure. Ravage procedure and Nuss procedure. Ravage procedure is an open approach. So this is performed via open approach. In Nuss procedure, we use minimal invasive approach. Clear? So just opposite of pectus excavatum, in which there is sternal depression, there is pectus carinatum, in which there is sternal protrusion, and that's why it is also known as what? Pigeon chest. So here can you see there is sternal protrusion, and this protrusion is mainly prominent in which part? Middle and lower part, right? So this is known as pectus carinatum, and the other name of pectus carinatum, it's also known as pigeon chest. This is pigeon chest. Now what is the problem here? You can see the sternum is protruded or elevated above the level of ribs. And what is the most common type? In the most common type, the middle and lower part of sternum and costal cartilages are involved. So here you can see that the sternum is elevated above the level of ribs. Okay. Now what is the most common type? So it's the anterior displacement of, there is anterior displacement. So what is the most common type? There is anterior displacement of middle and lower part of sternum with associated costal cartilage. Okay. So the most common type, there is anterior displacement of middle and lower part of sternum, middle and lower part of sternum plus adjacent costal cartilage, right? This is more common in males, and in certain patients there is mitral valve disease. It is associated with mitral valve disease and coarctation of aorta. Okay, so this is more common in males. And what are the associations? Mitral valve disease and coarctation of aorta. So here also most of the patients are asymptomatic. Their main problem is cosmetic problem. Okay, so the clinical features, patients are asymptomatic, the only problem is cosmetic problem. So there is only cosmetic problem. Clear? Now what we have to do, since there is anterior displacement of sternum and lower costal cartilage, so we have to mobilize this sternum and costal cartilage to its normal anatomical position. So in treatment, what we do, in treatment we perform the mobilization of sternum and costal cartilage, sternum and costal cartilage to its normal anatomical position. There are one line of questions related to chest wall tumor also. So see the questions related to chest wall tumor. Okay, so first question, that what is the most common chest wall tumor? It's the metastasis. So chest wall tumor. So what is the most common chest wall tumor? It's the metastasis. Second, what is the most common primary chest wall malignancy? Primary chest wall malignancy, then it is chondrosarcoma. So most common primary chest wall malignancy. Clear? And this is chondrosarcoma. Chondrosarcoma. And what is the most common primary benign chest wall tumor? Then it is osteochondroma. So see, most common primary benign chest wall tumor. Benign chest wall tumor. So the most common primary benign chest wall tumor, and this is osteochondroma. So you have to remember these three statements because these are frequently asked in exam. Clear? So this is all about thorax and mediastinum.